this special fireside chat at LM 2025. And our guest today is someone known for speaking plainly, leading boldly, and reshaping healthcare system with both humanity and innovation. As the president and CEO of SCAN Group, Dr. Jain has brought national attention to how we care for older adults and how to bring meaning back to healthcare, both for patients, for clinicians, and for our healthcare leaders. So Sachin, thank you for joining us this evening up for our...
Thanks so much for the opportunity to be here. Really appreciate it.
What a pleasure. Thank you. So first of all, I want to ask this question, and I know everyone just heard about your bio. You have had one of the most diverse healthcare experience, right? Staying from careers in healthcare, spanning from clinical experience, obviously practice, federal policy, innovation, and leading one of the nation's most mission-driven healthcare organization now. So tell us about how did it all start, and how do you see yourself with this diverse experience and shaping who you are today as a leader?
Well, thanks so much. Really appreciate the opportunity to be here. My journey started in a very exotic place, Bergen County, New Jersey. I had an Indian American immigrant parents, and when I was growing up, my father basically said, son, you have two career choices. You could either be a physician or a doctor. And I will tell you, I struggled with it. One of them sounded more regal, one of them sounded more pedestrian. So I leaned regal and I chose physician. But the truth is that I really wanted to do it my way. And my dad said, look, once you go to medical school, you can kind of do whatever you want. And a big part of my upbringing, with really my dad as my mentor, was really thinking about broader societal problems. And from a very early kind of stage of my career, I had this sense that healthcare is broken and we need to fix it. And in college, got the opportunity to study under two kind of leading thinkers around health systems change. One was Don Berwick, the former CMS administrator, but then really the father of the modern quality movement, and Howard Hyatt, who had been the dean of the Harvard School of Public Health. And both really inspired in me kind of this view of a career as a physician activist, a physician leader. And so as I progressed in my career, really wanted to try to fix healthcare from different vantage points. But I think about myself a little bit like Diogenes, the famous Greek philosopher who was on a search for an honest man.
Yeah.
And I've been searching for an honest person in healthcare, and I haven't found one yet. No, I'm kidding. I'm kidding, but I've worked in every sector of healthcare and have been trying to fix it from different perspectives. And I think over the course of my journey, have developed some theories about why healthcare is as broken as it is, and which brings us to the topic that we're talking about today, which is really, I think we have a leadership crisis in U.S. healthcare. I think we need a greater degree of activism. I think we need more... Thank you. But I think how you actually define a problem ultimately influences how you solve problems. And I think our problem definition has been exceedingly superficial. And the problems that we face in U.S. healthcare are far deeper than payment policy or quality improvement or whatever the superficial causes that we ascribe to the broken nature of our healthcare system. We've frankly just lost sight of what it is that we're actually trying to accomplish on behalf of patients, which is why I find this gathering so meaningful and so interesting. I feel like this is a group of people who really want to try to create change, both at the individual patient level as well as a systems level. And it's a movement whose time has really come. So I'm just thrilled to be with you all here today.
Well, thank you for saying those words. That means a lot. But first of all, I think what you just talked about, value in the healthcare system, and I just wanted to sort of bring back to that conversation. Over time, value in healthcare has become so tightly linked to payments and economic constructs, and has literally lost that meaning with what matters to patients. So how do you define value in healthcare, and how can we create a healthcare system that meets that definition?
Look, I think value in healthcare is probably the most bastardized term over the last 20 years. When you really think about kind of the fact that we talk a lot about value-based care, but at the ground level of clinical care delivery, value-based care is really risk adjustment. It's just coding. It's just billing, right? It's not really about actually taking care of patients.
Right.
And the truth is that there's a lot of people who've written lots of great papers and given lots of great speeches about value being equal to quality over cost or whatever famous equation you want to use. But at the end of the day, the reality is that what value really is just improving the health and lives of the people that we serve. And again, I'm a little bit old school in this regard. I think it's about exercising professionalism. I think it's about respecting patient autonomy. I think it's about guiding and supporting people with compassion and care. And a lot of that has been stripped away because we've gotten so obsessed with measurement in US healthcare that we have lost sight of what we're actually measuring. And I think a little bit about The Little Prince, which is a book I read in high school French class. Many of you probably read The Little Prince at some point. And the most important line from that book is that which is important is invisible. That which is important is invisible to the eyes. And the truth is that we are focused so much on what we can actually measure that we've lost touch with the intangibles, the hard to measures that actually form the basis of what really good care actually is. And I think that's the work that we have to do, is to kind of recenter on a view of healthcare that really emphasizes and values the immeasurable things that actually are most important to people.
Yeah, you bring up a very important point about the quality measures and measurement in general. We call it industrial complex now, because just the number of quality measures which are really putting clinicians so much pressure and burden. We actually did a deep dive on analysis of quality measures, especially the clinicians, our clinicians use. And we learned that most of them are neutral, but there aren't many that actually benefit our community or incentivize in general. And there are a few actually would penalize even though we deliver better care. So I couldn't agree more. I think the measurements, and there are people who are talking about we should just get rid of quality measures. I don't know what you think.
Look, I don't think we need to get rid of quality measures, but we do need to really balance it a bit. I think, in the absence of quality measures, there is a bit of a wild west of clinical care delivery, but I think what you measure ultimately impacts what we deliver. And I don't think that there's been enough attention to it. I also think we've just saddled ourselves with too many measures.
Right.
I think we need to focus on a few measures at a time, get better at those particular measures, and then move on. And instead, we've actually just stacked more and more and more measures on people,
right,
to the point where we spend more time measuring things than we actually spend doing things. And the balance is completely out of whack. And we just don't do anything about it. And frankly, we create more measures and more measures and more measures, to the point where I think we've lost sight again of what is most important to patients.
I agree. So I love your origin story of SCAN, especially. I think you talk about that 12 angry seniors who were simply fed up with the system and decided to take matters in their own hands. And in a similar way, I would say ACLM was born from a group of frustrated physicians who wanted to change how medicine was being practiced. So both movements started with frustration, but turned into a purpose. And how do you see that same spirit driving real transformation in healthcare today?
Yeah, so for those of you who don't study managed care companies and don't track this industry with great purpose, SCAN is not a radiology company. When I first heard the name SCAN, I said, what a stupid name for a company. And 5 years later, I was leading the company. So, God or whoever you believe in is actually quite funny when they want to be. But the reality is SCAN was actually founded as the Senior Care Action Network in 1977 by a group of people we affectionately refer to as the 12 Angry Seniors. And it always puts a smile on people's face when we talk about 12 angry seniors, because you don't think of your grandmother as being angry. You just think about her as being a sweet old lady. But at the end of the day, our founders were 12 angry seniors. And these were people who were living in Long Beach, California, and wanted to age differently. They didn't want to end their life in a nursing home. They wanted to age in place. And so they set about to build a set of services that would actually help people actually stay in place. And then, like all well-intentioned people, they eventually get corrupted by capitalism, and they became a Medicare Advantage plan. And I bring that up. I bring that up because a lot of what we've done, and I don't think the 12 Angry Seniors got corrupted, but I think the organization over time went from being this soul-driven, community-based, grassroots organization to a Medicare Advantage plan. It provided a business model that actually enabled that service delivery. But I think it's a cautionary tale for you to think about here at in your organization,
College.
The College of Lifestyle Medicine, in that you can sometimes actually stop being about the thing that you think you're about, and you start becoming about a payment model, or you start becoming about a philosophy, and you stop actually practicing common sense. And I would say SCAN went through a difficult time where we were toxically positive about our own impact. And the truth is that that's what managed care in America has done across all companies. We literally contract networks and pay claims, but if you were to go to one of these companies, they would say that they're saving lives. And I think it's the same cautionary note I would say for you all, which is I think we're started with such a pure mission, which was to recenter patient care around lifestyle elements. And I think, I would just share that I think one of the things you have to do as an organization evolves is just make sure that you're actually staying true to the founding purpose. Yes. And that's something that we've tried to do at SCAN is get out of this kind of view that our work is to be a great Medicare Advantage plan, but instead really focus on the founding notion, which was we're here to keep seniors healthy and independent. And it's easy to start to get high on your own supply. You and I were joking before. You said, "Oh, we have 500 residency programs that use the lifestyle medicine curriculum," and I said, "I'm sorry, Padmaja, I don't believe you." Just because it's hard to get one residency program to change, much less 500. So again, I think it's really important to kind of really ask yourself hard questions about, are we actually doing the things that we say we're doing? Or are we just kind of getting proud of ourselves for things that aren't necessarily really truly tied to the thing that we actually are doing?
I want to build on that because I think you're giving us really good advice here as a college. But for us to make lifestyle medicine, broader, or have lifestyle medicine adopted more broadly, what is it that we should do or we should not do? Like, what advice would you give as a college or for all of us who are trying to promote lifestyle medicine across?
Look, I'm new to your world, so I don't want to be that guy. Okay, there's always that guy who's like, "Oh, I'm here for 5 minutes, and I'm going to tell you exactly what I think about what you need to do differently." We have enough of those people.
It's important because even from outside, we want to see what perception.
We have enough of those people in healthcare. But what I'll say is the following: is I think you have kind of two main risks at the risk of sounding pedantic. One is it's actually like definitional. What is lifestyle medicine? And I think the truth is it's a vague enough term that people can project onto it whatever they want to project onto it. And I've seen that happen to you all, where people look at lifestyle medicine and can easily kind of veer it in the direction of not evidence-based, or they can veer it in the direction of anti-medicine, anti-allopathic medicine. And so I think there's a real vagueness to the term, and I think that's the opportunity, is to be very forceful about defining what it is in every opportunity that you can, and activating this whole group of people to be really forceful about a clear definition: what is lifestyle medicine and what is it not. The other piece of advice I'll share, and again, I really don't want to be that guy, but it's very easy to become about your own thing and just kind of create a tribe that's kind of completely separate from like where everyone else sits, and just be very comfortable in your own tribe and develop your own language and develop your own approaches and have your own conference. And I would say you should have your own conference, but your work coming out of this is to go infiltrate the rest of American medicine. so that the ideas that you're kind of, I think, propagating, which are the right ideas, become mainstream instead of becoming fringe. And that's harder work. It's way easier to kind of set up your own club, right, so to speak, as opposed to changing the club that everyone else is part of. But I think you need to do both. You need to kind of keep strengthening your own group while also simultaneously trying to drive change in kind of the traditional house of medicine. And I think if you do that, before long, the people who used to think of, outcast you will start actually saying your words out loud. And it'll feel funny. It actually feels really funny because, at the end of the day, these are the folks who didn't accept you in the first place who are now kind of adopting your agenda. But that is what success really looks like here.
Well, thank you. And I have to say this, that last year, 2024, ACLM was inducted in AMA, so House of Medicine. We now belong there for sure. And we have made now in the last 2-3 years been very intentional about making strategic partnership, extending ourselves from our own circle, going more mainstream and partnering. And we are seeing that now, the momentum building around whether it's the federal payers or whether commercial payers or employers or health systems. So there is clear recognition and interest in adopting more of the principles, care models, and really to improve healthcare in general, improving outcomes and overall also lowering total cost of care.
Sure.
So,
I mean, the other thing I would just encourage is, pay attention to when leaders change. Institutions are highly conservative.
Yep.
And I've spent my whole career trying to change institutions from within. And so that, again, this is hard-fought, learning. But what I would say is that, every time a CEO turns over for one of the kind of main organizations of House of Medicine, that's an opportunity to influence a new person to think a little bit differently, to help set the agenda. So whether it's Dr. Oz at CMS or John White at AMA, there's a lot of legacy people with legacy thinking who are just committed to ideas from 30 years ago.
right.
That's just the nature of how people lead oftentimes. They remember what they studied 30 years ago, they haven't learned anything new, and that's what they're gonna kind of stick with. But when you actually have new people in roles, there's oftentimes a renaissance in institutions and organizations that enables you to actually capture a part of the agenda. And so I think that's part of what you all have to do, is to try to take these kind of pivotal changes. And I think you are doing that. I mean, I think I'm super impressed by the work you all are leading here, but I would say lean into that more.
Perfect. Thank you. So we have been championing whole person care long before it became a buzzword. But now suddenly everyone is talking about it. And from your perspective, what is whole person health, and how does SCAN Group really offer that to their members?
Yeah, so from my perspective, whole person care is one of the most polluted terms in US healthcare right now. I mean, it is. So my wife is a member of a health insurance plan whose entire tagline is whole person care. But when she has a medical problem, she actually has to call 4 different phone numbers. And that's what they call whole person care. Those of you who know health insurance companies know who I'm talking about. I'll just leave it vague. But what I'll say is that whole person care is ultimately about actually just treating humans like humans. And I have a term that I use a lot, which is radical common sense. Which is, common sense shouldn't be radical, but in healthcare, common sense is radical. But it's like actually solving someone's problem the first time. It's actually thinking hard about the root causes of what's actually happening to someone and actually addressing it. Whether it's a behavioral issue, whether it's a food issue. And I first got exposed to this when I was leading CareMore Health, which is an innovative healthcare delivery organization that kind of cut its teeth in the risk-based Medicare Advantage space before it was as regulated as it is. And so when they had a senior who was at high fall risk, the doctors would actually go to the person's home and set up grab bars, and they would set up ramps. When somebody was getting dehydrated multiple times and admitted multiple times, they would go ahead and buy an air conditioner and actually install the air conditioner in the person's home. And when they had insulin, they set up a refrigerator. They made sure that the person had a working refrigerator. again, there needs to be more radical common sense when we think about healthcare. And I would say that's what whole person care really is. It's going back to the underlying root causes and thinking about what's needed, socially, what's needed humanistically, what's needed from a family perspective to actually address the person's needs. But unfortunately, again, I think the term has gotten super polluted by business interests in healthcare who frankly see whole person care as a dollars opportunity as opposed to a service opportunity.
Very well said. So I remember you...
I'm not cynical at all, guys. I just want you to know. Cynicism is just, you need to know, cynicism is just optimism that is covered with experience. So, I just need to make sure you all know that. So.
Yes. I remember you sharing at the White House conference on hunger, nutrition, and health that SCAN had been offering medically tailored meals to its members long before food as medicine became a buzzword. So what inspired that you wanted to sort of offer that as an offering to your community, and did you look at some evidence or?
No, this comes from the 12 Angry Seniors. Look, this is common sense. The fact that food influences health. God, you guys have a conference on it. I'm glad, but I think even Hippocrates knew that,
yes,
right?
Yes.
And so the main point is that these community activists, when they were kind of thinking about what actually influenced health, they're like, well, you can't get to a medical appointment unless you have transportation. And so they set up a transportation service. They said, look, you can't actually really be healthy unless you have healthy foods. And so they set up a meals program. And so I think it goes back to really thinking hard about what are the basics that need to be in place. Unfortunately, as we've industrialized food, right? Yeah. We just it's like a check the box activity for so many healthcare organizations, so many managed care organizations. It's just kind of a table stakes thing that they need to have a food card or a benefit. I think the opportunity to innovate in that space is really a big one. Mm-hmm. It's a place where I think you all might want to play more because I do think the health literacy space is a big challenge around food.
Yes.
Because most people think that foods that are very healthy or unhealthy, very unhealthy are actually healthy, and these belief systems persist long beyond the evidence base, right? It gets revealed. So I actually think even though that this space has been around for decades now, there's still a lot of great work to do, and it's an opportunity for focus for all of you.
Yes. Let's move on to physician leadership. I know you talk a lot about
oxymorons. I don't mean that disparagingly. I'm a physician. My father was a physician. What I mean is that there is a learned helplessness that comes with being a physician, and I can say that it's like everybody's at fault except for us problem. It's a real thing. It's a real thing. And maybe you guys will shoot me on my way out, and that's okay. I've lived a long life. But the point I'm trying to make about this is we really are trained along the way. I'm a physician executive at this point. I don't consider myself a frontline physician. I do a little bit of patient care, just to say that I do. But the reality is that I don't get my primary vocation at this point is not as a physician, right. But I stay connected with a lot of my friends who are full-time practicing physicians, and we have text threads, and all they do is complain all day. I mean it. It's kind of sport at this point. And so I really do think so many of us get this learned helplessness. It's part of the hidden curriculum, that it's the administrator's fault, it's the insurance company's fault, it's the pharmaceuticals company's fault. It's everyone's fault except for our own. The minute you start talking about some of the things that physicians might be doing wrong, it's everyone's fault again. And again, I think we have a leadership opportunity to show up differently, collectively as a healthcare community. And I think if you go to most healthcare corporations, physicians are actually marginalized. And I think it's a little bit because of how I think business interests view physicians, but I think it also has to do with how physicians show up in those settings, where we do have an obligation to be the voice for patients, the voice for healthcare, the voice for evidence. And we sometimes lose our way too. That's the other thing that happens. We become code switchers. We have physicians who work in business and in healthcare who end up actually showing up more like business people than as physicians. And so I think we also have to kind of really make sure that we're standing for the things that we stand for. And it's uncomfortable.
Yes.
It's very uncomfortable. But the great thing about having a national physicians shortage is you can shoot your mouth off and say whatever the heck you want and get a job tomorrow down the street making more money. I mean, I say that half jokingly, but that was a little bit part of, what my father told me. Is like, look, at the end of the day, if you're a physician, you're always going to have a job.
Yes.
And you're always going to be able to go somewhere and take care of patients. So when you have that kind of personal security, I think there's an incredible opportunity to actually be the voice of change and actually say the things out loud that need to be said. But so many of us are grumbling on text threads and in our physician workrooms, and we're not saying the things out loud that need to be said. And some of it is also learning how to say those things, and then frankly supporting your crazy colleagues when they do speak up, and being somebody who actually is an advocate and a supporter of change. And many of us become too change averse. We really like things. We hate things the way they are today, but we don't want them to change at all. That's really the kind of paradox of that we're trying to solve for. And so I just think that there is some work that we have to do to kind of raise a generation of physician activists who know how to thoughtfully challenge the status quo.
Yes, and let me ask you, as a leader yourself, you developed a reputation of speaking truth to power, right? Even when it's uncomfortable or unpopular. And that kind of candor is not easy, especially in a world that rewards diplomacy over honesty. So where does that courage come from? Is it something you always had all along, or is it something you build over time?
Look, I think when we talk about leadership in the 6th, 7th, and 8th grade, we talk about Gandhiji.
Okay.
We talk about Malcolm X. We talk about Martin Luther King. And then we go to work at healthcare organizations, and we talk about leadership, and we talk about the division chief, the department chair, or the hospital CEO. And I don't know, I haven't met a CEO that reminds me of Martin Luther King. So, the point, so I've talked a lot about word pollution here, but we've polluted the word leader in healthcare. And a lot of leadership, I think, is speaking uncomfortable truths even when it isn't in your own best interest. And the hidden curriculum of leadership in most healthcare organizations is that you've got to be some sort of committee diplomat, politician, who just doesn't say anything. And then that also goes along with not doing anything.
Right.
But when you actually look at what's broken in healthcare, it really requires activism and action, and it requires cultures that enable that and support that. But a lot of healthcare organizations kind of teach you to numb yourself to the uncomfortable realities, numb yourself to the fact that really bad things are happening, that we could do where we could actually behave and operate differently. And again, I think we need more voices for change. Now, to go back to what I was saying before, the one person who stands up and says the thing in the department meeting or sounds like a crazy person when they say it, because like everyone else has been socialized to just kind of taking everything as it is. But what if we actually trained ourselves to be advocates and support that first person who speaks up? And then a second one of us speaks up, and the third person speaks up. Then that first person's act of courage doesn't feel like such an outlier. But too often, we have that person who speaks up in the department meeting, and they're like, man, can you believe John? He's crazy. He said out loud what we were all thinking, but he's crazy. He won't be here next week. And the truth is that we all need to be allies for people who do have the kind of comfort and the gumption to say out loud the uncomfortable things. And that's how culture change actually happens. It doesn't happen when we just normalize the abnormal. And unfortunately, that is what we have allowed for so much in healthcare. We have normalized abnormal things. We've normalized 7-minute office visits with patients and treadmill-like behavior. We've normalized team-based care where no one's actually practicing in a team. They're just practicing alongside each other, not with each other. So we have to kind of stop being complicit in a broken status quo. And I think, again, we all become sheep instead of leaders of the flock, and that's what we need more of here.
Thank you. That's a good one. And I want to say this group is definitely that activist group that you're talking about. We are challenging status quo. This is really why we are here in this. And this very fact that ACLM was founded was, we were just not happy the way the system was working. We realized there was plenty of evidence out there, yet patients never received the root causes of treatment when it came to the chronic disease management. So clearly, this is the group that truly believes in challenging the status quo. Yes.
Yeah, and there's something about groups of people who challenge the status quo. And I'll just say, there's moments in history where their time has come, right? And I would say for all of you, I think you're in one of these moments. Whether you're Democrat or Republican, a lot of the themes and topics that you care about are now being discussed at the federal policy level.
Yes.
And so these windows open up, and you've got to shove as much as you can through those windows, and you have to do as much as you can with those windows. I think you're in one right now.
Yes.
And that would be my only encouragement to you, is to take advantage of this moment where we are talking about making people healthy again. And again, I worked in the Obama administration, so you can that tells you where my politics are. But what I would tell you is that there's some really good people who are thinking a lot right now in this administration about how to actually do more of the kinds of things that you all want to do. And so this is not a time to be a Republican or a Democrat. This is a time to actually be somebody who wants to create social change. And that's what I would just really encourage you all to do.
Thank you. Thank you for saying that. That's so important. So I know you warned publicly about ethical erosion in U.S. healthcare leadership. And what do you mean, and where do you see it most? Is it a slow drift, or is it something you think it's more systemic?
So I first encountered the term ethical erosion when I was a medical student, and a medical educator said to me, there's this ethical erosion problem in healthcare. We start out with medical students who want to help homeless people, and then they all become dermatologists. And I turned to Bill Taylor, that was the faculty member. I said, Bill, I think you have it all wrong. I think they wanted to be dermatologists all along, and they were just lying to you in their essays. But I will say most people get into healthcare wanting to help people. I actually believe that. Most people, whether it's in the clinical side of medicine or the business side of medicine, actually start out wanting to help people. And then 30 years into a career in healthcare, they're talking about their second home and putting their kids through college. And they've forgotten where they started. And the erosion starts from the very first time that you actually have a job working in healthcare. You get exposed to this hidden curriculum of the business side of medicine, the business side of healthcare, and you hear these tired tropes like no margin, no mission. If somebody says that to me another time, I will jump off a building, okay? Because nobody's actually asking the question, is the mission just in the first place, right? The mission of most health systems is to perpetuate themselves, right? It's not to make people healthy. It's not to create healthier communities. The truth is that most hospital systems should actually aspire to have fewer patients in their hospital beds. That is the mission of most hospitals. That should be the mission of most hospitals. But instead, these tired administrators who don't pause to even think, and these code-switching doctors who are at the helm of these institutions are like, no margin, no mission. No margin, no mission. We can't do the right things without making $1. But what if the right thing isn't actually having patients, having a full ICU?
Wow.
But the truth is that we let them get away with this because we don't challenge this topic. We don't actually participate in the ways that we should, and we don't influence the boards of health systems to say, you shouldn't run this health system the same way you run the local bank or the local hat manufacturer. But the truth is that we in healthcare have allowed ourselves to get equated with other industries. And there's nothing about the healthcare industry that is a parallel to any other industry, because we're engaged in the human endeavor. We're engaged in human health. Nothing is more personal than human health, but we allow ourselves to compare ourselves to Avis and Hertz. And every time you do that, you cheapen ourselves. You do, because we're doing something completely different. But I think we need to start the work of actually exposing boards of health systems, boards of hospitals, to the idea that maybe growing the next big tower is the wrong answer, right? And that maybe we should be investing more in outpatient care than we do in inpatient care, and we should have payment models and align with payment programs that allow us to do that. But I will tell you, the moment that made me most cynical in US healthcare was actually coming out of the passage and the implementation of the ACA and going to look for a job. This is a true story. So I finish 2 years in the Obama administration, go back to finish my internal medicine residency, and I really fall in love with these ideas of population health and accountable care and risk-based healthcare. When you sit in Washington during that time, you get exposed to all the interesting work that's going on all over the country. And so I went to go interview for jobs at the big health systems in Boston and New York, and I was looking for a job trying to implement some of the population health programs. And I got offered all kinds of interesting jobs, and then I said, but what's your real level of commitment to this work? And the truth is, none of them were interested in this work because it didn't feed the fee-for-service treadmill that they were all addicted to at that point. And so I did what any rational physician would do in that situation, is I went to work for the pharmaceutical industry. I kid you not. I'm a Boston-trained physician. I was trained to hate pharma. I was trained to hate pharma. It's a very anti-pharma environment if any of you have spent any time in it. And I was like, these folks don't actually want to change anything at the health system level. They don't want to realign payment. They don't want to realign the system around value. It's taken 20, 30 years to kind of shift the business model. Where's the leadership in that? And again, my misadventures in pharma are a topic for another day. But what I will say to you is, again, I think that we have allowed healthcare organizations to get away with bloody murder. We bankrupt patients. We literally bankrupt patients. Healthcare is the #1 source of bankruptcy in this country. We have repossessed patients' homes because they weren't able to pay bills. It's absolutely insane what we've allowed to have happen in US healthcare. So again, I think we have to retake the soul of our profession a little bit.
Powerful words, thank you. So let's talk about traditional Medicare. I know you have a lot of opinions about that. What is working and what is not working now? And if you were to, say, redesign Medicare, what would that look like?
Look, traditional Medicare, in its original form, was an amazing program. And it just has failed to keep up with the times. And unfortunately, today, traditional Medicare is a rich person's Medicare program. You just have to look at, kind of the co-pays, the co-insurance, how it actually works. And if you can afford it, it's a great program, because it allows you to go anywhere and see anyone and get anything done. But the reality is that most people can't afford it today. And so that's why Medicare Advantage, 25% of seniors were in Medicare Advantage in 2010. Today it's 53% of seniors are in Medicare Advantage. And I'll say Medicare Advantage, I run a Medicare Advantage plan. Lots of problems in Medicare Advantage too.
Yes.
But the reality is Medicare Advantage done right actually could set up the financial incentives to enable people to be kept healthy and not reward systems for when people are sick. Now, many healthcare organizations, we've had a lost generation where we haven't done that because too many health systems and too many healthcare organizations got too addicted to risk adjustment and coding. But when you see Medicare Advantage really working, health systems will take risk on that population. They'll get some big percentage of premium from the health plan. And then they will use that capitated payment to then invest in more intensive management of chronic disease and more primary care, and actually try to keep patients out of the hospital. That is what really good Medicare Advantage does. But traditional Medicare just pays you when you get sick. And that's the fundamental flaw in traditional Medicare, is that being a fee-for-service system, it just kind of, it only works when you're consuming care. And that's the dynamic that we really need to fundamentally change.
But let's talk about Medicare Advantage, which is probably going to cost $84 billion in 2025 more for beneficiaries. I mean, as per MedPAC's result, we can't necessarily sustain that.
Yeah, look, we can't, and I think there's work being done to kind of right size it, and I would say, one of the kind of key challenges though is that Medicare Advantage overall covers more than traditional Medicare does.
Yes.
There's vision benefits, there's dental benefits, there's audiology benefits. These are all big gaps in the traditional Medicare program. That said, I think there's too much money flowing into Medicare Advantage because of risk adjustment and because of some of the skews in the program. And so I think those are the things we need to fix. But at the end of the day, I think capitated payments are more aligned with kind of the principles that you all care about than fee-for-service medicine.
So if you could reimagine Medicare, traditional fee-for-service, with a clean slate, how would you embed lifestyle medicine into benefit design, care delivery, and quality measurement?
I think one of the biggest challenges in health insurance in general is you can't actually improve anyone's health in one-year increments.
Yes.
So we're like completely sub-optimizing for what needs to happen. So if you're actually interested in improving health over the long haul, you need to think about it over 5 or 10-year periods. And so health insurance products, whether in the Medicare space or the commercial space, probably should be 5 or 10-year products as opposed to 1-year products, which would enable health plans to actually invest in year 1 in things that will actually yield better outcomes in year 5 and year 10. Today, running a health plan, you're making an investment in year that's going to actually improve your financial bottom line in year 1. And so the actuarial cycles are always kind of misaligned with, I think, the things that you all care about, which is improving lifestyles and actually driving improvements in outcomes over the long haul, and creating durable outcome change as opposed to moment-in-time outcome changes. That requires a completely different approach to actually financing healthcare. And so if I were you all sitting in front of Dr. Oz, I would say to him today, make Medicare a 3 or 5 year enrollment as opposed to a 1-year enrollment. That is the thing that will align payment with delivery in the way that you want to deliver it.
Thank you. I love that. So, as you know, as you were coming here for this fireside chat, I have a few friends who have also submitted questions, and one of them is Karen Johnson. She's the Vice President of Practice Advancement at American Academy of Family Physicians. And her question is, you have written about pilots and demonstrations often being used as a cover, a way to appear open to change without committing to real change. In your view, what is the biggest smokescreen in healthcare today that organizations use to signal progress while avoiding true transformation?
Look, the biggest smokescreen is the one I talked about, which is the no margin, no mission smokescreen, right? It's not really contending with the hard challenges that organizations face. But to expand upon Karen's question and maybe just say a little bit more about it, how many of you have actually tried to change something in a large healthcare organization? Anyone? So my first time was I was a second-year medical student. I observed this kind of phenomena on rounds where patients would be asked questions and they didn't have time to even compose their thoughts, and then the medical team would run out. And so I said, why don't we have a notebook at the patient's bedside so that they can actually write questions down and we can review the notebook every day. This was just a dumb second-year medical student idea. And so I went to see someone to talk about it. They said, great idea. And why don't you go present it to the hospitalists? So I was like, I thought I was big shit back then. So I was like, I'm going to present to the chief of hospital medicine and all the hospitalists, and I'm going to go. And they were like, this is a great idea. Why don't you go present it to the nursing leadership? And I was like, okay. Then I was like, okay, I'm a real big deal now. I'm getting to see everybody. And then I understood the game, which is the ping pong ball, right? They were just wearing my ass down. Okay, sorry to be so colloquial on a Sunday evening, but that's what they were doing. A year and a half later, I was still talking to people about my stupid notebook, okay? And I finally gave up on the notebook. And that is the work of trying to change healthcare. They wear you down, right? Common sense is uncommon. We are taught that change requires massive amounts of consensus, useless consensus, pointless consensus. And so as a result, we kind of year after year keep proposing the same ideas and keep proposing the same ideas. The funny thing about being CEO, it's a dirty little secret about being a CEO, is I realized that change just happens when I want it to happen, right? And institutions are either set up to actually make things change or actually grind change to a halt. And I think there's an opportunity for healthcare organizations to be run differently. Think about how quickly institutions moved during COVID. For years, we talked about, we can't do telemedicine, we can't do this, we can't do that. Like when we needed to do it, we freaking did it.
Right.
And I will tell you, it was the first kind of national scale demonstration that there's a virus in healthcare organizations. And I'm not talking about COVID. I'm talking about healthcare administration virus, HAV, in case you didn't know about it, okay? It is the virus by which healthcare administration is set up to do absolutely nothing for years on end, right? So, but I would say to you the following, is demand more, be better. I'm just telling you, and in fact, become a healthcare administrator, I'm telling you, so that you can prove to people that it can be done differently when you are actually in a position of authority, that it doesn't have to be all politics, all consensus driven all the time. So.
Good. So a lot of us think that maybe of all the value-based care models out there, maybe Medicare Advantage is perfectly sort of ideal for lifestyle medicine. Would you agree that?
100%. But I think Medicare Advantage, as it has been implemented in most people don't really understand Medicare Advantage. I would love to come back and spend some time with you and give everybody here like a 101 on how to actually make it work for lifestyle medicine. Happy to do it. I don't think we don't have enough time to do it today. But here's what I'll just say about it, because again, most people don't live with this day in, day out like we do. Health plans get a capitated payment from CMS, a risk-adjusted capitated payment, a stars-adjusted, risk-adjusted capitated payment, based on the severity of illness for that patient. So, it could be for a healthy member, $1,000 a month. For an unhealthy member, it could go as high as $3,000 a month. You're talking about modifying things for the $2,000 to $3,000 a month patients, right? If you could take the $2,000 or $3,000 a month, which is risk adjusted to pay for hospitalizations for this population, and instead use those dollars to pay for exercise interventions, to pay for food interventions, to pay for intensive chronic disease management, you could change everything. You could literally change everything. But the truth is that most of your healthcare organizations, if they're participating in Medicare Advantage, are either doing it on a fee-for-service basis, they're not taking full risk and then operating in a capitated way to actually use those dollars and organize care differently. Or they're taking capitation and are just focusing on risk adjustment. They're not actually focusing on re-engineering care process to better take care of patients. And I will say, it is the #1 opportunity to change healthcare that doesn't require another policy fix, doesn't require a single change. It just requires organizational will and commitment to do this. One organization that's doing that right now in partnership with us at SCAN is Sutter Health in Northern California. We're in year 1 of a many-year partnership, but they want to do the big things, they want to do the small things, they want to change how care is really delivered. And again, I can give you lots of little pockets of where this has happened around the country. But again, I think health systems are so addicted to fee-for-service for the most part, and so unaware of kind of alternate ways of actually doing business, that it's going to require leadership from people like you to really drive the kind of change that we're talking about within them.
And I'm going to take you up on that.
I'll do it.
We'll do that one-on-one, yes. So we have 3 minutes, and I want to just open up these questions for our audience. If they have any questions, if they can go ahead and send. I think, Leslie, if you have any questions. Yes. So what are core measures would you prioritize to reliably track lifestyle medicine outcomes in a way that reflects quality care, supports advocacy, and aligns with payer expectations around value?
So I think this is a problematic question. And I'll tell you why. It's one of these things. I remember, again, I'll just say in medical school, there was an environmental medicine group. They had a lecture. They wanted to have, a curriculum on environmental medicine. And then you had a domestic violence group, and they wanted to have questions. And one after another, you're kind of stacking things in to the clinical encounter to the point where you can't ask the patient like what they're there for because you're busy going through this long list of things that you need them to do. And I would just say, like, maybe we're trying to do too much in this question, right? Like, maybe we should just focus on like one or two things that really connect reliably with someone's outcome. So like the percentage of diabetics in someone's practice who have an A1C less than or more than, right? Or the delta, how much you were able to move someone's metabolic outcomes, and just leave it at that. Trying to align with a payer expectation around value. I don't know. I don't know if it can do all that. But I'm just making a case for parsimony today, which is, let's just think about 3 or 4 things that you could align around, that you could go take to Dr. Oz and say, these are forget all these other measures that you have right now. In fact, I know for a fact he wants to blow up the star rating system. He's said it on a few different occasions. So what if you replace the current star rating system, which doesn't really measure, the quality, that applies to 53% of Medicare beneficiaries, and just had 3 or 4 that you guys figured out, had some consensus around, that really aligned? It could change everything. It really could.
Right. Love that idea. Thank you. Thank you. All right, I think we're almost out of time. Thank you, Sachin, for your honesty, your clarity, and your leadership. This conversation actually reminds me that, rewriting the healthcare playbook is not necessary. It's already being written. With your leadership and with all of us working around, I think we're already rewriting the playbook anyways. So we'll keep doing the work. Thank you, everyone, for joining this evening.
Thank you so much.
Thank you, Sachin.